registered nurse can't deliver one baby a year under a critical situation and maintain competency.
Right.
Thank you.
Yes, that's a good point. Very good point. Well, we now hear from Andrea Cassidy, who's a registered midwife and representing the midwifery collective of Essex County. I hope. Is she here? Oh, yes, so good. I think that's an excellent idea.
So Dr. Chan is on call tonight for a birth, and this is why I'm the one speaking in case she was not going to be available here. So first off, I'd like to say thank you for letting me speak at this really important meeting tonight. And I'd like to say that we're representing a collaborative group of maternity health care providers that have been involved in developing an innovative project in this community. There are nurses in the audience that are part of this collaborative team. There are managers from the hospital. There are administrators. Terry was very involved in this. So this is, there's two of us, but there's lots, okay? I have a PowerPoint, which is awesome. Okay. So there's a lot of conversation about the 50% of women who are choosing to go and birth in Windsor, but not enough emphasis on the 50% of women who are staying and birthing in this community. So I'd like to talk about who is birthing here. So I'd like to describe somebody who represents a typical woman who's birthing here. Let's call her Helena. She's having her 8th baby. She's due in May after the proposed closure. Her family has one vehicle. She doesn't drive. Only her husband drives. She doesn't speak English or read it. Her husband speaks a little bit of English and reads very little of it. He works in the greenhouses. They have a low income, like many others in this area. The median family income for this region is 35% lower than the rest of the country. As mentioned, she's had 7 other babies, all very quick deliveries. The last one was born in an hour. As common to women who have had a lot of babies, she had a postpartum hemorrhage after delivering that last baby. Helena and her husband are both very happy with the care they got at Leamington Hospital and wanted to have their next baby there. 70% of the women who come to Leamington are from the Mennonite community, like Helena. Many of them have not even driven to Windsor before and will face unique barriers and likely adverse outcomes if they cannot birth in their own community. Leamington is resourced as a level 1 hospital, as you know. That means it is resourced to handle low-risk births. 80% of the births in all of Ontario are low-risk births, which implies that Leamington is the right setting to handle the majority of births in this community. Because it's not resourced to handle the remaining 20% of high-risk births, it will never, and nor should it ever be expected to cover 100% of the births in this community. As stated earlier, Leamington should only be considered for the low-risk births, or 80%. Leamington is currently providing care for 62.5 of that group. The numbers that have been circulating around are misleading because they are based on Leamington being able to provide care to 100% of the births in Leamington. Well, this should never happen. It also does not take into consideration that 20% of women who cannot safely deliver here and are better serviced in the larger centers. It does not take into the fact that Many of these high-risk women use Leamington as a safety net for triage and assessment to ensure their well-being and that of their babies before they travel to those larger centers. LTMH frequently arranges emergency transports for these women to Windsor. In the past months alone, Leamington has delivered a number of high-risk women who could not have the ability to make it to Windsor in time. As the board, you are aware that the Erie St. Clair LHIN's latest strategic plan has a mandate to prioritize service and remain sensitive to the needs of the community, particularly those that are vulnerable. Yet this very population you are putting at risk and making them even more vulnerable by asking them to birth away from their home community. And you're asking them to travel at least an hour, if not more, with traffic or weather to access any form of maternity care. The proposed closure very much veers away from the Ontario government's mandate of putting patients at the center and providing them with the right care, right place, at the right time, which is close to home and not an hour away. What does follow the government's mandate of putting patients at the center of the system is an innovative proposal on collaborative care, the first of its kind put forth by a team of maternity care providers. It has been submitted to the Ministry of Health and has an initial favorable response to already. I'd like to spend a few minutes talking about this innovative solution to the decreasing numbers of healthcare providers in rural communities and the positive gains we can get from this solution. We call it the Leamington model. Our proposal was submitted 1 year ago. The Leamington model is a collaborative model, unique in its scope, an innovative solution to the problems that small rural hospitals face with obstetrics. It's the first of its kind in Ontario. The project is a fruit of a collaboration of many providers. There are obstetricians, family physicians, nurses, nurse managers, hospital administrators, family health team administrators, midwives, doulas, and consumer focus groups. The proposal is a joint project between the Midwifery Collective of the Essex County, Leamington District Memorial Hospital, Leamington and Area Family Health Team, the Windsor Essex Community Health Center, and researchers from the Faculty of Nursing at the University of Windsor. Innovation, leadership, and collaboration are at the heart of this proposal. It's innovative in that there are no other models like this in Ontario. There is one other model that exists in this country. It's similar to what we're proposing, but not exactly the same, and it has shown excellent outcomes. The model is creating a sustainable integrated obstetric program at Leamington, which uses shared resources from among midwives, nurses, obstetricians, and family physicians. The midwives in this proposal would be placed within the family health teams to offer midwifery care. This will be the first time that midwives are collaborating in a family health team. This proposal will make it possible to also bring obstetrical care to some of the outlying communities that currently don't have access to it. All low-risk women will be offered or can choose exclusively to receive care from a midwife, obstetrician, or family physician. The final option that will be offered to them is a shared care model, where they can have their pre, postnatal, and birthing care provided by a team that includes all of the above providers. Women in labor in the hospital will receive a much higher level of labor support with the introduction of a doula RPN training program. A postpartum clinic will be offered to the women at the family health team. Also postpartum home visits, which is part of the current midwifery model that has resulted in a 90% success rate in breastfeeding, will be brought into this model as well. This proposal addresses stability for maternal health care for the Leamington Hospital by ensuring better work-life balance for providers. It addresses the demands of providing obstetrical care 24/7, 365 days a year, in rural communities where there are very few providers to share this workload. This workload, in conjunction with the decreasing numbers of obstetrical providers throughout Canada, has led to what is being called the maternal health care crisis. In Ontario, we're down to 6% of our family physicians that provide obstetrical care. For every OB that graduates, one retires. Midwives turn away 40% of women who want our care. This decreasing number of maternity health care providers is a significant contributing factor to an increase in infant and maternal mortality rates in Canada. In 1996, with comparable countries, Canada was number 6 for infant mortality. In 2006, we have slipped to the place of 21st for infant mortality. With maternal mortality, we have moved from second lowest rate to now the 11th highest. This is very concerning. National and governmental organizations have asked for the development of maternal collaborative teams to aid in affecting these shocking numbers. We need to work as a team, and this has long since been the call across Canada. We here in Leamington are willing and able to be leaders in this collaborative maternal care. There are 3 main barriers to collaborative maternity health care. These barriers are significant, as demonstrated by the complete lack of collaborative maternity health care teams in Ontario specifically and in Canada in general. Differences of philosophy of care, different scopes of practices, and funding. Within this community, we have found solutions to these barriers. We have excellent communication and trust among the providers. We have a similar philosophy of care. Therefore, over the last year and a half, we have co-wrote this innovative model. We developed this in conjunction with focus groups from the women in the community. Midwives will be working in an extended scope of practice approved by the College of Midwives of Ontario. This will bring in line the scopes of practice for the providers. Funding is our final barrier. We have approached the Ministry of Health with our model, and their response has been very favorable. They saw our project as innovative, a leadership approach that can be exported to other rural hospitals that face similar sustainability issues with maternity health. We have partnered with a researcher from the University of Windsor at the Faculty of Nursing to evaluate the model so that it can be reproduced in other communities. After a series of productive consultations with the Ontario Midwifery Program, the proposal will be in the position to overcome this final barrier with a positive endorsement from the LHINs and the stability of the Leamington OB unit. Midwives will play a key role in this project. Midwives have excellent outcomes such as low C-section rates, high breastfeeding rates, low readmission rates. When we talk about the 80% of women who are birthing out here, that's the low-risk group. When we talk about quality of care, you need to look at the national rates for that 80%. It's not the high-risk women we're worried about. Across this country, it's the low-risk women we are concerned about. We have rising numbers of C-sections, rising number of intervention rates that cause complications. It's the management of these low-risk women that we do in Leamington, and we do really well. Midwives offer a choice of home and hospital delivery. However, providing safe hospital delivery is not sustainable without the timely access to a hospital and physician care. To answer the question about timing, the research midwives are new. We've only been around for 20 years, so we don't have a definitive answer. We look to the Society of Obstetricians and Gynecologists across for an answer to this, and what they say is you need to be able to reach a hospital within 30 minutes. When you lose birthing in a community, and that's what this means, birthing options will disappear, home birth and hospital birth. You lose the option for prenatal and postnatal care because it's not sustainable for the providers to stay in a community that can't provide obstetrical care in. The experience of birthing at Leamington Hospital is unlike what the larger hospitals can provide. In fact, it's quite similar to a birth center experience. As you can see at Leamington, the quality of care is exceptional. With what Leamington Hospital offers, it shouldn't come as a surprise that the women who birth at Leamington Hospital report a 90% satisfaction rate compared to a 53% nationally. And this could also explain the trend in birth numbers with a 33% increase in the last year. We have a C-section rate of 6.9 compared to the provincial rate of 15.4 for low-risk pregnancy. That's that 80% we keep talking about, and that we're concerned about the quality of care for those women. Our born report card, as has already been said, shows that our episiotomy breastfeeding rates are below the provincial average. Leamington's quality of care surpasses the provincial expectation. So why would the Erie St. Clair LHINs miss the opportunity for its level 1 hospital to build on this existing strength and allow for the potential of this healthcare team to approach its realization in creating a model that will show leadership for this community and for other communities within your area? I ask the LHINs to reflect on the unique population that will be losing birth with the closure, women like Helena. The LHINs states a commitment to better care, better experience, better value. We have shown that Leamington OB unit and the proposal from its care providers is aligned with this goal and shows leadership and innovation in maternity care. We offer you a solution that makes Leamington a leader in this province when it comes to collaborative maternity care, and offer a model that could be emulated in other parts of the province. Our birth numbers this year have increased by 33%, and when we apply the numbers we already know, we're capturing 62.5% of the low-risk births in this area. I have observed that hospital leaders, former presence, would always welcome increased funding, but not at the expense of other key health care providers in a community. Removing and shifting maternal health care from a vibrant rural community to a larger urban center like Windsor would be another example of a shift to an urbanization of health care. I ask the board to show leadership in improving access and patient experience by maintaining birth close to home.
Thank you, Andrea. Dr. Chan, you want to make a comment?
I didn't make a formal presentation, but I just wanted to address some of the things that have been mentioned tonight, just so that there's not any confusion in the community. When I learned that the plan was to close our obstetrics unit, my gut reaction was, I'm out of a job. But the focus should be on the community and the needs of the community. So, as you've heard, I will obtain privileges in Windsor Hospital if that needs to happen. But my priority is to support this community. And if the delivery room here stays open, then I will continue to provide care in the community. There's been a lot of focus on the actual delivery itself, but I think what we're losing focus on is that there's a whole 9 months of care that occurs before that actual delivery. And as you've heard from many of the speakers today, a lot of our patients don't have access to go to Windsor once a month, once a week, twice a week, whatever it is. And that's why I've decided to keep my clinic open, so that for the clinic visits that occur for the 9 months before the delivery, that access will stay here at home. When it comes time for the actual delivery, I do sincerely worry because I know that a lot of my patients will not make it to Windsor. If the delivery room closes, we will have to be more innovative of how to provide safe care to these women, which may include planned inductions, which is one way of circumventing some risks, but it increases other risks. So, as a care provider that's been in this community for 5 years and has seen the unit grow and prosper, I have a very vested interest in keeping it open and seeing it continue to grow and thrive. And that's what I'm here to do.
Okay, thank you very much. Do we have any questions from the board members? Barb?
Well, first, I want to thank you for bringing up the fact that Leamington District Memorial Hospital delivers quality care in its OB/GYN unit. So I think that's very important, and also to the dedication of Dr. Chen. That is also very important. And in terms of the midwifery program and the proposal, I think it's a very innovative proposal, and certainly one that speaks to the collaboration that we're looking for at the LHIN. I have a couple of questions in terms of what is the percentage between home births of the midwife program and those at the hospital? And then the second one would be, have you also looked at collaboration and partnership with some of the immigrant associations here in Leamington and the county?
So I would say that the home birth numbers provincially are 20% for midwives. I don't know what the numbers are in this community, but the ability to provide safe home births in this community will be in jeopardy with the closure of the OB unit. The collaboration with the immigrant community in here, all the providers in this community absolutely include women from that community. A vast majority of the women I care for come from that community, and there has been, in creating this, outreach and focus groups with the women in the community about willingness and interest in accessing a team, and the response has been very favorable from the women in the community, that they would be open to a collaborative maternity health team.
And just further up, do you see that that population cohort is going to be increasing in the Leamington area? Do you have any?
Yeah, I don't know.
Okay.
Do you know?
Quick comment would be if they're having 8 babies per family, yes, they are.
Thank you.
Any other questions?
It just
from the board?
speaks to patient volume maybe at the OB/GYN unit. Thank you.
Any other questions from the... I just have a request. As you know, Andrea, thank you very much, by the way, and Dr. Chan. As you know, the LHIN does not fund the midwifery practice directly. It's funded directly by the Ministry of Health and Long-Term Care. The first time we saw your proposal was 2 days ago. So if you have any additional information associated with that proposal, I think we would very much appreciate it. Even though we don't fund midwifery practice directly, it sounds like you're asking us to be a support, if we can, in that endeavor. So we would appreciate whatever correspondence or information you sent to the ministry. Okay?
Absolutely, I can provide that.
Thank you very much. Thank you both. So we have one more presentation, then we'll take a short break. So if we could have Bruce Crowder, Chief of Essex Windsor EM.